detour in London, you could actually go to the Faraday Museum, where you could see some of the original induction coils. And actually, Faraday was a pretty prolific inventor. And if you want to skip Big Ben and Parliament and those boring parts of London, you can go straight to the Faraday Museum, where you can see a whole bunch of artifacts that were among his inventions. So the embodiment of the induction coil from Faraday is presented in this device. It was first put into use in the early 1980s by Anthony Barker in Wales. And since then, just about every device has been about the same. They all have the same components. So you can see here, the operator is holding an electromagnetic coil. It's connected to a steel cable. That's connected to a capacitor. The capacitor is plugged into the wall. The capacitor here charges to about 10 kilovolts. And then through a circuit element called a thyristor, which is something that allows a circuit to dissipate energy very rapidly, the entirety of that large capacitor, or at least a big fraction of it, gets discharged very rapidly to create a strong magnetic field that will turn on and off over about a quarter of a millisecond. Because that magnetic field fluctuates, it behaves like a spinning magnet. That is, that there's a fluctuating magnetic field, it will make electrical current everywhere around it, including in the brain, if you position it next to the scalp. And you can see in this case, the operator, this happens to be Tony Barker, who invented the device, is holding the coil over the right hemisphere of this patient. And this volunteer, I should say, has, you could see on her hand, an EMG electrode to record the motor evoked potential. And that's in fact where I'd like to focus a lot of this discussion, which is on the easiest part of the brain to stimulate to know that you've adequately stimulated it. The motor cortex talks back to the operator immediately in the form of a contraction of a muscle. And that contraction can be quantified with a surface EMG. And so one could record the motor evoked potential from TMS. TMS is very well tolerated. It could be done across ages and really hasn't changed that much in the decades since it's been around. This is a picture of Gabby and Natasha, our RA and secretary, and they're holding a relatively modern device, and this is the old device. They're essentially the same, except the new device has a couple of bells and whistles that I'll show. One of them is this interesting capacity to track the position of the participant, at the same time tracking in 3D the position of the stimulating coil with a stereo camera, and then identifying for the operator where on a reconstruction of the patient's brain the current is landing. Now, the TMS coils themselves, I just want to talk a little bit about the anatomy of them, are interesting in the way the circuitry is structured. The most common kind of coil, especially the kind that's used to stimulate the motor cortex, is something called the figure-of-8 coil. In the figure-of-8 coil, there are two oppositely wound Archimedes spirals, that's the cartoon here, so that the current sums at the center and falls off at the periphery. So functionally, even though this coil is about the size of the palm of somebody's hand, the part of the brain that's stimulated is only about the volume of a fingertip. And if it's particularly focal, it could even be about a ½ centimeter on edge voxel. So in fact, TMS turns out to be a relatively focal method for non-invasive cortical stimulation. And in fact, that's probably an adequate summary for what TMS is. It's a focal method for non-invasive electrical cortical stimulation. The M in TMS is in fact not relevant to the neuromodulation properties of this technique. It's just a vehicle to deliver electrical current. And so TMS can actually be quite focal. And not only is it focal in terms of the distribution of the electric field, it gets even more interesting when we think about the anatomy of what we might be stimulating. And realistically, exactly what we stimulate in terms of neuronal elements is a little bit still of a black box. We should keep in mind that when we're stimulating by TMS, we're not doing exactly what we would do if we were to stimulate within an isolated brain slice, where we could find a white matter tract, stimulated precisely, record from a bundle of cell bodies or dendrites. In the TMS protocol, we stimulate the head. We're stimulating glia, we're stimulating endothelia, we're stimulating skin, and we're stimulating neurons. Obviously, the ones we're interested in are neurons so far, but which neurons we stimulate by TMS is still not entirely known. Of course, the caricature that we use for what TMS does looks something like this, where we just stimulate some region of brain. The reality is we are still stimulating a gyral structure. In that gyral structure, there are gyral crowns, gyral lips, sulcal troughs, etc. And the orientation of individual neurons within those is necessarily different. And the axonal and soma and axon hillock, etc. orientation may make a lot of difference as to what is it that we're actually stimulating. And this has yet to be worked out, but there might be a value add to identifying what this cellular anatomy is that we're stimulating, because then we could be somewhat precise about what cell types we're biasing toward when we're stimulating. It is not entirely known yet what we're stimulating. The thought is probably we're stimulating something on the gyral crown and gyral lip more often than not. And in the motor cortex, we can have a readout of that. Because if we know where the hand omega is, for example, on the precentral gyrus, and we stimulate that and we get a contraction of intrinsic hand muscle, we have some corroboration that our hypothesis is right, that is, we stimulated where we thought we're stimulating, and the electrophysiology holds up. But realistically, what we stimulate neuronally, we don't yet know. And a lot of the work to identify what neuronal elements and what their geometries are that are more favorable to activation actually came from here. And this was the work of Paul Maccabee and Vahi Amassian largely, who identified in humans by studying the TMS effect on optic radiations and in vitro on isolated axons, including cool giant squid axons, what kind of orientation lends itself to depolarization the most. Unfortunately, neither Paul or Vahi are with us anymore, but this really was an essential set of articles that anybody's interested in TMS we advise reading. That described actually the biophysics of TMS in a very practical way. So the modern values of TMS actually enable us to do really cool frameless stereotaxy. So the TMS device, the capacitor of the coil, hasn't changed much in decades. But in the last 10, 15 years, there have been very convenient additions to the TMS setup that include the addition of a stereo camera that tracks the position of a patient. That patient or participant can have infrared reflectors put onto them, and then scalp landmarks that are unlikely to move, like the mesion or the Cruz helix, could be registered, as can the skull surface, so that ultimately the operator has a very good impression of where the electrical field is landing on a participant's brain. And again, what I'd like to talk about is stimulating the motor cortex. In fact, you can see a little dot here in the precentral gyrus. And if we do that, the motor cortex talks back to us in the form of a motor evoked potential that can be recorded with surface EMG electrodes. Now, this is actually a very safe technique. It can be done across ages. Our indoor youngest record is 7 months of age for a patient. These are one patient and one healthy participant in the study of hemiplegic cerebral palsy. And these are well tolerated. You can see these kids are wearing the EMG electrodes, and you can in fact do TMS across ages. There is an age where kids are non-negotiable, and between 2 and 4, they won't keep the electrodes on. So it's a little bit of a rodeo, but otherwise, this is actually a very well tolerated technique. And so the product of one of these TMS sessions where we attach electrodes to predetermined muscles and then stimulate the hemisphere is something that looks like this. Here's an example of an abductor pollicis brevis EMG. And you could see here the junction of the red and blue arrow correspond to where the stimulus landed. You can see the central sulcus here on the precentral gyrus, and only a single channel of otherwise 6 channels of active EMG is giving us a deflection. And this deflection has an amplitude and a latency. And so you can actually have something really valuable for electrophysiology. You could have an input-output curve. and an input-output curve in vivo in a walking, talking human that can tell you how excitable is the cortex. And that's actually, we'll talk about it some more, is a really interesting feature of the motor cortex. It's well enough connected to the rest of the brain, to deep nuclei, to cerebellum, to the other hemisphere, to the rest of the frontal lobe, etc., that it can become a good surrogate for how excitable the brain is. And one interesting use of the motor cortex in epilepsy is as a surrogate for cortical excitability as a whole, which you can imagine could be very abnormal in epilepsy and could be changed by an anti-seizure intervention. And so any kind of cortical stimulation can be divided into roughly 3 types. Single pulse stimulation, where you stimulate once and get an evoked response. A very interesting protocol of paired pulse stimulation, where one delivers a conditioning stimulus followed by a test stimulus, and the response to the test stimulus is modulated by the conditioning stimulus. And depending on the interval between those two, you could really stress the circuit that you've stimulated with this pair of stimuli to get a sense of its GABAergic inhibitory tone. And this becomes also a valuable tool, as you can imagine, in epilepsy if we want to identify how intact is cortical inhibition. And then there is repetitive stimulation, which is an FDA-approved technique. Some TMS devices are FDA-approved just exactly for repetitive stimulation, which would take advantage of things like long-term potentiation and long-term depression to modify regional cortical excitability. And it's repetitive stimulation that's FDA cleared, for example, for treatment of major depression by TMS. So I'll focus on these maybe in this order. Single pulse TMS, paired pulse TMS, and repetitive TMS, see what's so good about it, and what can we do in epilepsy. So the first one we already talked about. This is actually what we do in day-to-day. Our TMS program, the clinical one, is filled more often than not with patients who need motor mapping before surgery. It could be tumor surgery, it could be epilepsy surgery. In children, motor mapping functionally is actually very hard to do by techniques other than TMS. So children do not cooperate well with functional MRI, neither do adults with developmental delay or anxiety, etc. With children in particular, the threshold for motor cortex activation is high, it declines with age. And so intraoperative monitoring for motor evoked potential also is difficult. And so TMS motor mapping, this is actually the brain of a 4-year-old, has fallen into a really interesting niche where we could have somebody with minimal discomfort sit for TMS, and we can identify where in their brain we can stimulate to produce a motor evoked response of a pre-specified muscle. So this is the right intrinsic hand muscle APB map for this participant. These pixels are where the stimulus landed. They're color-coded in to indicate the amplitude of the motor evoked response. And we can see the hotspot is exactly where you would expect it in this brain, in the hand knob of the precentral gyrus. Just like we can map the intrinsic hand muscle, we can map the tibialis anterior in this patient. And again, you could see it appears right about where you would expect it. So we can produce meaningful motor maps for patients in whom there's a question of whether or not the seizure onset zone, for example, overlaps with the motor cortex, or in patients more and more who have very unusually shaped brains. Obviously, as you can imagine, in child epilepsy, we deal with dysplastic brains or brains that have accommodated a perinatal stroke or tumor or something else. And so then the question is not just, is this the motor cortex? One practical question is, where is the motor cortex? And again, this is something we can do by TMS with a very well-tolerated technique for a population for whom fMRI doesn't often work. WADA is too coarse. Intraoperative motor mapping also is not very practical. So this has fallen into a neat niche. This is an example of a use case in a patient of mine. This happened to be a teenager, but you could see actually this patient's low-grade glioma is underneath the precentral gyrus. You can actually see the effacement of the gyrus here in the panel. And it's in a dominant hemisphere for a very functional adolescent. So we're able to map the first dorsal interosseous muscle as a representation of an intrinsic hand muscle in this case. And the FTI map corresponds to this region in this patient's brain. We could map the tibialis anterior and then put these two together, the foot map and the hand map, in a way that allows a corridor through the precentral gyrus for the surgeon to access to remove this tumor without disrupting either dominant hand or dominant foot function. And that's indeed what happened with this kid. This kid is actually now a very successful biomedical engineer who invented a new kind of colposcope recently. So Back to this example. So here again is the APB map for this participant. And what's so good about an epilepsy? Well, one use case, of course, is mapping the motor cortex before some kind of surgery. Another interesting use case is measuring cortical excitability. And from this motor evoked potential, we can get a sense of how excitable is the precentral gyrus. But the precentral gyrus is so well connected to everything else that we can get a sense of how excitable is the brain as a whole in this patient. And from the motor evoked potential, and I won't belabor the details here, one could derive any number of metrics. Measures of paired pulse inhibition, paired pulse facilitation, threshold to activation, an interesting entity called the cortical silent period. So if you have somebody volitionally contract the muscle and you stimulate their motor cortex, that muscle will involuntarily relax. And how long it relaxes for is a function of how much GABAergic tone did you activate by stimulating the corticospinal tract. And all of these metrics potentially have some use in measuring the excitation inhibition ratio, which in epilepsy, of course, is important. So I'll focus on one of them because it's easy. It's easy for us to obtain. And this is the motor threshold. And we do it as a matter of routine when we want to do TMS for most purposes. In other words, one interesting question whenever you apply TMS to somebody's scalp is, are you applying it with enough amplitude? Are you inducing enough current to activate the cortex? Well, the place you'd know that you're activating the cortex best is the motor cortex. So the threshold to the motor evoked potential is exactly what it sounds like. You stimulate until you have a response, and at the stimulus intensity at which you have the response is the threshold. Below that, you shouldn't have a response. Above that, you should have the response reliably. The industry standard for what we call a motor threshold is somewhat arbitrarily the stimulus intensity at which one gets a 50% probability of evoking a motor response of 50 microvolts from a preset muscle. That's kind of how we do it. And here's one example. The MO abbreviation in this case in the right panel stands for machine output. And that's usually the unit that we use for stimulation intensity, which is the fraction of the capacitor that's discharged into the coil. And we can see in this example, discharging the capacitor at 33% of machine output doesn't produce anything, neither at 34, and reliably at 36, we get a motor response. So the threshold we say here is at about 35. The threshold to activation actually becomes a practical metric for us because it tells us how easy was it to excite this brain. And it has a pharmacology to it. It's predictably, for example, increased by voltage-gated sodium channel drugs, carbamazepine, ascorbazepine, etc. They will increase the threshold, as you can imagine, because anything that stabilizes the membrane would have some resistance to activation. And not surprisingly, if you give somebody Dilantin and measure their motor threshold, the motor threshold goes up. And this is actually another interesting use of TMS in epilepsy, which is identifying target engagement by therapeutics. So established therapeutics is not a big trick to see whether or not the motor threshold, that's what on the y-axis is here, increases when you give carbamazepine or lacosamide. And it increases in a somewhat dose-responsive way. But then for less established drugs that are in development, this becomes a useful tool. So for example, there is a drug in development now. It's called Xenon 1101. It's going to be a voltage-gated potassium channel Kv7.2 positive allosteric modulator. One wants to know whether or not that drug has engaged the brain at the dose you think it'll engage the brain in vivo and in human. And one of the things you could easily do, and this is what in fact what the investigators did here, is measure the change in the resting motor threshold by giving placebo or an established drug like retigabine, a potassium channel opener, or the experimental drug, to see if you have target engagement. Does the motor threshold move? And that can tell you whether or not this drug A works, B, have you given enough of it? And it's an interesting way to track pharmacodynamics and target engagement by developing therapeutics. This Xenon story actually has been around for a few years, and I think this is a drug that'll come to market probably in the next calendar year. That you could actually see on the bottom right a dose-response relationship. A serum concentration versus a change in the motor threshold on the y-axis, and you could actually get a sense of a dose-response relationship of this drug and the effect that it's had on the motor cortex excitability. And this is also an interesting value add of TMS, because in addition to checking serum concentration, you actually look at the organ in question and ask whether or not you've changed excitability in the direction you want it to change. In principle, in epilepsy, you want to reduce excitability, so raise the motor threshold. So it's interesting to find that a drug X can raise the motor threshold, which means that you've probably given enough of it to affect the brain, and it's affecting the brain in the direction that you want it to be affected. Yep. So that's another interesting use of TMS in epilepsy. And this is not just for drug development, and that's actually a few companies working on this TMS biomarker and its cousins to identify target engagement and pharmacodynamics of their molecule. But another cool place to use motor cortex TMS might be in measuring the epilepsy as a whole, and looking at disease severity or disease response to treatment. And so this is a really cool, very old figure already at this point from 2010. And let me walk you through this, because this is one of the cooler studies. And so what the red and gray squares here show is the resting motor threshold in an individual who presents to a first seizure program in Australia, who's then given a drug to start a daily anti-seizure drug. And then these patients either do or don't continue to have seizures. And if we sort these participants who started an anti-seizure drug into ones that are responders, they don't have seizures anymore, or the ones who are non-responders, and we look at their motor threshold, and in this cohort of, this is an idiopathic generalized epilepsy cohort, you could see that the seizure-free participants post-drug have an appreciable increase in their motor threshold. The participants who got the same drug at the same dose but did not respond have no appreciable change in their motor threshold. And that's a cool way to look at the motor cortex, because again, it's connected well enough to everything else that it could actually reflect not just target engagement by a drug, but potentially meaningful effect by an anti-seizure drug. Did we move the brain in the direction we wanted to move? Did we make it any less excitable? And you could actually use that to forecast the likelihood that an anti-seizure intervention will work in an individual. Again, that adds something to serum concentrations, especially for drugs that have very broad therapeutic indices. You never know if you gave enough until you look at the patient and they come back with their seizure diary. But here, potentially, by TMS, you can have this measure of target engagement to know that you've given enough, or to fail fast and go on to the next agent or polypharmacy. And here's something else that's a work in progress that I'll share with you, and I'd appreciate any comments or criticisms. But what we're doing is, as a matter of routine, we're mapping the motor cortex before epilepsy surgery in children for the most part. And we necessarily have to measure the motor threshold in everybody who comes in, because we have to map at above the threshold for activation of the motor cortex, otherwise the maps don't come out. And so if we look at this motor threshold in the left and right hemisphere, in all right-handed individuals with epilepsy, where by selection criteria, none have an injury to the corticospinal tract, and nobody has a seizure onset zone in the precentral gyrus. So they have a normal corticospinal tract by MRI and by exam. Not surprisingly, we'll have somewhat of a difference between the left and right hemisphere in the motor threshold. So the y-axis here is the motor threshold. The units in this case are volts per meter, which is actually the induced electrical charge. But it works the same as the percent of the capacitor that's discharged. But not surprisingly, the dominant hemisphere looks a little bit different than a non-dominant hemisphere in right-handed people. There's a slightly lower motor threshold at baseline in the left hemisphere compared to right. Now, if we then look at the post-operative outcomes for these patients, so all of these patients went on to have surgery. All of them have had a seizure onset zone hypothesized and then resected. None of them had resection or any injury to the corticospinal tract during surgery. And then we ask ourselves, was their epilepsy cured? And the threshold for curing epilepsy, we set relatively high, Engel 1A score. So you guys may be familiar with Engel scores. Engel 1 corresponds to no seizures. Engel 1A is really no seizures, no auras, no anything. It's as good as you can get, and you probably come off your medication. And then we ask ourselves, could we predict, not from the motor threshold, but from this ratio, which typically is a lower threshold in the left hemisphere than in the right, whether or not this patient will have a favorable outcome after epilepsy surgery. And it turns out that in the patients who do not, I hope that comes out clear, that's a no, angle 1A, who do not have an angle 1A outcome after surgery, there is a disproportionate number who have a right hemisphere lower motor threshold, which is in contrast to the endogenous left hemisphere lower motor threshold. And our thought of this is something interesting because it holds up statistically, and this is pilot data. We've since done it a little more, and the stats hold up, that in a right-handed person, typically the left hemisphere is a little easier to excite by TMS in our lab. If that left hemisphere is no longer easier to excite, then whatever disease process there is for this patient's epilepsy has involved more than just something very confined. It's involved at least the motor system, which probably means it's a more diffuse process than something very focal in epilepsy, which means potentially we can have a motor cortex readout of how diffuse is this epilepsy and whether or not we're likely to have a good seizure outcome after surgery. So that's another way that we're trying to use this measure that we obtain no matter what when we're doing cortical mapping to tell us something about this patient's disease and something about the likelihood of this disease responding to treatment. So let me quickly blast to paired pulse TMS, because there's a quick drive-by through what we're so good about single pulse TMS and the motor threshold. And let me just quickly review what a paired pulse protocol is. In paired pulse TMS, like paired pulse any other kind of stimulus, two stimuli are delivered the same way. And as you can imagine, after the first conditioning stimulus hits the motor cortex, it will activate a regional GABAergic interneuron surround. And if you give it a few more milliseconds, it'll activate circuits that that part of cortex is connected to. It'll bounce to the thalamus, it'll bounce to the other hemisphere, it'll bounce to the cerebellum, etc. And then all of those will feed back to the motor cortex. And essentially all these structures and regional cortical inhibitory interneurons feed back with an inhibitory tone to the motor cortex. So by the time the second stimulus, the test stimulus, lands on the motor cortex, if you give enough time between the two consecutive stimuli, the size of the second of the two motor evoked potentials is never as big as the first. It's predictably smaller. And it's smaller again because we've now activated very non-specifically a range of GABAergic inhibitory circuits. Now you can do this in humans. Interestingly, you can also do it in TMS, in rats. So you can do TMS in animals pretty much the way you do it in humans. Here's an image of a lightly anesthetized rat, and we can record two motor responses. The size of the second response is not as big as the first. I'm showing this picture of a rat because TMS and non-invasive brain stimulation, in fact, lend themselves very well to translational work. Because if you have a hypothesis, you can test it in an animal. Since it's non-invasive, well tolerated by humans, you can then forward that hypothesis to something rational in a clinical trial. So one of the places where we've been doing this is in traumatic brain injury. And let me just focus on this as a syndrome. You might already be familiar with post-traumatic epilepsy. It actually happens to be the most common way for young adults to acquire epilepsy. And the unfortunate natural experiment that usually happens is that there's a young, healthy brain, then there's an injury, the patient goes to the ICU, they come out of the ICU, and then nothing happens for months and months and months. And then some fraction of these patients develop epilepsy. To us, this is an insight into something quite valuable, which is not just epilepsy, but the process of epileptogenesis. How is the brain transformed from non-epileptic to epileptic over these months? And we are actually, as a laboratory, but as a field, very interested in this process because of the 40-something available anti-seizure drugs. Right now, exactly 0 are anti-epileptogenic. Not only that, the trials that have been tried with phenytoin, valproate, magnesium, levetiracetam, lacosamide, you name it, haven't worked. And so there is a field out there looking for something that's an anti-epileptogenic as opposed to anti-epileptic intervention. traumatic brain injury is one of these syndromes where you could actually study this process of epileptogenesis. Now, you could study it in humans. You can also study it in animals. And in animals, it's very, in fact, easy to produce post-traumatic epilepsy. This is an image of like a Rube Goldberg kind of device where there's a hammer that hits a piston that generates a fluid pressure wave. That wave then indents the dura, and that puts pressure on the cortex, and that causes a contusion, and then a mix of dying and surviving neurons, which is in fact what you need to make epilepsy. If you just ablate brain, it's a good treatment for epilepsy. You really need this mix of cell death and cell survival to make an epileptogenic focus. And then about 6 weeks later, these animals develop electrographic seizures, very much modeling the human scenario of initially no epilepsy, and after a latent period, eventually epilepsy. And one could ask whether or not by TMS, which measures cortical inhibitory tone, so by this paired pulse stimulation in the motor cortex, you could track a gradual loss of cortical inhibition in post-traumatic epilepsy. So that's in fact what Henry and Sean, our postdocs at the time, did with this technique of paired pulse stimulation. They asked whether or not in an injured rat, over the 6 weeks that it takes for the animal to develop epilepsy, there is a progressive loss of cortical inhibition. And we think that part of the epileptogenic story in this latent period is some degree of neuronal cell death, but that neuronal cell death is not equally distributed among neuronal types. It actually seems to be biased toward inhibitory interneurons. And we could ask whether or not in this period of time after injury, there is a loss of cortical inhibitory tone that you could pick up by TMS to identify that epileptogenesis has been engaged. And if you just look at these images, you could see on the bottom is an injured animal panel that in the first week after injury, there's still a smaller size second response than the first. There is paired pulse inhibition, which presumably GABAergic paired pulse inhibition. But as the animal progresses, there's a gradual loss of the magnitude of this inhibition. In a sham animal who's not been injured, this inhibition is maintained. So we could use this paired pulse protocol to take a cohort of animals that have had a sham injury or real injury and ask every week, how's your cortical inhibition, et cetera, and see that in the injured group, there's actually a gradual loss of cortical inhibition. So on the y-axis is the ratio of the second of the two responses to the first response. The second one is the numerator, first one is the denominator. So the closer the value is to 1, the less inhibition there is. So interestingly, we see kind of what we expected in this group, where by weekly TMS, we are seeing whether or not there's progressive loss of cortical inhibition heading to epilepsy. The potential use case of this in humans is to enable identification of those individuals for whom epileptogenesis has started. So one reason why we don't have an anti-epileptogenic drug is because it's miserable to try to run an anti-epileptogenic trial. Because if you have 100 patients with severe TBI, maybe 20 of them will get epilepsy. So it becomes impractical to expose 100% of patients to a drug that only 20% of them can use, and it may not work. An interesting tool might be to identify who is in that minority who's going to develop epilepsy, for whom epileptogenesis has started, and then it would be an interesting question to ask whether or not epileptogenesis has been changed by not an anti-seizure intervention, by an anti-epileptogenic intervention. Yeah. One threshold question is, could you detect something in this window that's otherwise invisible to the naked eye by some commonly available tool? So it looks like by TMS you can. Of course, in animals, we have the luxury of looking at the organ. So if we look at their brains, and we stain with a generic stain, a new stain that just looks for all neurons of all kinds, and we stain the perilesional tissue, not the lesional tissue, that one's going to be abnormal, but 1 millimeter away from the contusion by design, the layers actually look normal.
No. Yeah. All right. Well, I guess we'll go on like this, since the presenter mode isn't working. Let me know. Oh, perfect. Thank you. The cliffhanger is that if we zoom in on the provalment positive cells, we in fact can see that as a function of time, the numerals here correspond to weeks after injury, that there's a gradual loss in the perilesional tissue, in fact, throughout the brain, of provalment positive inhibitory interneurons. This is an interesting phenomenon that likely reflects some durable process that progressively and slowly injures the inhibitory interneuron cells. There's a couple of components to this figure that I'm happy to talk about offline, but one of them actually is you could see that the cells get fewer in number and a little bit darker. There's actually a dematuration of the provalment positive inhibitory interneurons where they make less provalbumin over time as well. And you may know provalbumin is a calcium chelator. It's necessary to keep these cells from accumulating enough intracellular calcium when they fire rapidly to not undergo apoptosis. So there's a couple of interesting processes that are triggered in these cells as a function of epileptogenesis. The cool part here is you could have something that's non-invasive, that's available in rats and in humans, that can tell you how your provalment positive inhibitory interneuron network is doing. And that I think is another interesting feature of TMS. Now, there's a mechanism by which these cells gradually drop out. And again, I'm happy to chat about this offline, but it actually involves a somewhat complicated series of events that includes a generation of an excess of reactive oxygen species, a loss of regional glutathione, an eventual increase in oxidative stress, which is what's imaged here. This is an 8-oxo-DG stain.
I think we're not seeing.
Oh boy, oh, this is really not working. Oh man. All right. Yeah.
So he's saying that that's for albumin or the standard, like we know the albumin might be decreasing, but other cells, how do you react that? Like, do you have what's our standard saying that just albumin of other cells?
Well, pyramidal cells, principal cells stay actually surprisingly intact in the perilesional tissue. Glia change a lot.
Does just neural cell staining show that, or even studies show that, like intact is?
Oh, that's interesting. In our lab, since there's only 27 hours in a day, we've not really gone beyond the inhibitory network and not even beyond the provalment cells. So we've been asking, for example, just starting with the somatostatin positive cells to see if they're altered in some way. We have looked at astrocytes appreciably, especially the astrocytic glutamate transporter, because we think that's a factor in epileptogenesis, and that changes also with time.
So how about inflammation, like the real?
Yeah, absolutely. There's.
That could be the. Yellow steroids will cure it.
Well, no, but you're on the right track. There's an inflammatory component. John, missing a shoe.
No,
Oh.
you don't have a shoe.
Couldn't we start PowerPoint?
Yeah, because we have disconnected to the PC.
Sorry, I can chat offline.
Yeah, I'll do that afterwards.
I could.
Yeah, we just wanted to restart the
Oh, sure.
PowerPoints.
You got it.
This is still locked up.
I think that it's the.
The Zoom is working. It's just the room projector not connecting to it.
Ah.
So we disconnect the room, connect and reconnect them. Just unplug.
But yeah,
Just unplug it.
epileptogenesis itself is fascinating. Which is probably why no one drug works. The trick might actually be combination therapy for preventing injury.
Sorry.
Oh, it's okay.
I'm zoomed in.
Oh, so this is better for the people on Zoom. Yeah, this is weirdly locked.
Yeah. I unplugged it and it's still not working, like the entire projector.
Click on the little screen, the small screen on the side, the power button.
There is.
No, on the small screen that should be.
No,
Maybe here.
Yeah. Power button. Yeah. And then. And now. And start up again.
Maybe let the Zoom people know what's happening.
Yeah, we're just trying to fix the projector here in-house.
So yeah, well, while we have this slide up, let me just focus on this for a second, since this one is up. So this is a really cool development story. So the PAR cells happen to be especially susceptible to injury. And the interesting feature of this kind of development cell loss is that it takes a while. So there's obviously an acute post-injury effect. There's some immediate acute cell death. Then there's the usual 48 hours of deficit number if you have a stroke. But then something happens on a scale of weeks to months. And it's a very interesting progressive syndrome that we see. It's progressive in time and it's progressive anatomically. So if you look far outside the lesion, even in the opposite hemisphere, gradually, by 6 weeks or so, you can see the bottom right panel, for example, the contralateral hemisphere. There starts to be a loss of phenomenon. So something is triggered by injury that spreads over time and over states, over anatomy. And we're trying to figure out what it is. And we're trying to see if you could have by TMS, particularly by this paired post-TMS protocol, which is probably so far the most convenient measure of GABAergic tone that we have. We can detect, one, that this process has started, and two, if we try to interfere with this process, that we've interfered with it successfully. Yeah, so that's the idea, and that's why I'm showing these slides in the TMS talk. And let's see if we have any more slides to show.
Somehow this one's not working.
Huh.
Now you're seeing the other slides on Zoom?
Yeah.
We could just log into Zoom.
Well,
We just talk to the Zoom people, we'll get it.
I suppose I can talk about this with just shadow puppets or hand gestures or something.
Describe your slides.
Yeah, I'll describe my slides.
Yeah.
I can do it without it.
So the microphone.
Yeah,
Yeah, close to the microphone. There are
So-
some questions on the chat as well.
that's great, guys. Sorry, guys. For one reason or another, the slides in the room are not advancing. We're all stuck on a single slide on number 43. But I'll talk to the room, and I guess the people on Zoom have the luxury of actually seeing the slides. Which is that we're looking for a mechanism, and that's what I was just explaining to the room earlier, by which this loss of parvalbumin is slow and progressive. And what we see with this 8-oxo-DG stain is that there is, in fact, after injury, a progressive gain in reactive oxygen species and oxidative stress. The reason why we think there is this gain is, since we took a little bit of time, I'll blast through a couple of these slides, is an interesting loss of a major glutamate transporter. And it's a loss of like the most highly expressed molecule that nobody's ever heard of. So one of the things we're studying is the astrocytic glutamate transporter in humans called EAAT2, excitatory amino acid transporter type 2. In mice, it's called GLT1. It's the same molecule. And this one transporter, which lives on astrocytes that wrap around excitatory synapses, is predictably downregulated in almost any kind of injury. So just about anything that causes reactive astrocytosis causes a downregulation of this major glutamate transporter. This major glutamate transporter makes up about 1% of total brain protein. So during regular business hours, we're just clearing glutamate all the time. It is really the major way for glutamate to leave the synapse. If not for this one astrocytic glutamate transporter, glutamate would hang out in the synapse much longer than it should, and maybe lead to excitotoxic injury or to something else downstream. It turns out that with any kind of injury, and this is from our lab, what we've seen in traumatic brain injury, the magnitude of this glutamate transporter, GLT1, at the protein level declines by about 50%. At the radioactive glutamate uptake level, it also declines by about the same amount. So there is this feature that we see, which is a loss of a major glutamate transporter after injury. And the people in the Zoom can see the Western blot. You guys can't, but take my word for it, there's less protein. Now, what happens when there is...
It's not advancing on Zoom as well.
Oh, it's not? Now both are stuck? Oh, no, I'm sorry, guys. I promise this is not deliberate and nothing personal.
Okay.
Should we just do a restart of the computer with that?
No, now it's working actually for the Zoom people.
For the Zoom people,
Yeah.
but not for us? I'm sorry, guys.
You can Zoom.
So everybody can see Zoom. Okay. Oh, that's cool. So if you guys can see it on your phones. So one interesting question is, if there's a predictable loss of this glutamate transporter, and let me just give a quick plug for the residents and students. So it's just the modern way to think of a synapse is having three parts. It's not just a presynaptic cell and a postsynaptic cell, which is the way I have it in my head. But realistically, the synaptic reality is much more complicated. And this is the electron micrograph that shows it. And one way to think about this is that almost around every meaningful glutamatergic synapse, there's going to be a nearby astrocyte that's going to buffer potassium and buffer glutamate and do a couple of other things that are very important. So thinking of a synapse as having three components, the presynaptic cell, the postsynaptic cell, and the astrocyte process is a very productive way to think about it, because in that astrocyte process are actionable components of pathophysiology and druggable targets. Yep. So what our thought in the lab is that if you have a loss of this glutamate transporter, I hope you guys can see this on Zoom, there will be necessarily an accumulation of glutamate in the synaptic space. Not only will there be an accumulation of glutamate, that glutamate may spill outside the synaptic space, and if it does, it may make for a bad gradient for a glutamate cysteine exchanger, which is exactly what it sounds like. It's something that puts glutamate out of the astrocyte into the extracellular space in exchange for cysteine, which is the critical component of synthesis of glutathione in the astrocytes. Why are we interested in this? Because we think part of the pathology that we see is this gain of reactive oxygen species over time on a scale of weeks after injury. One reason why we think there's this gain of reactive oxygen species is because what we have is a loss of glutamate transporter. With a loss of glutamate transporter, we think there is a pathologically altered glutamate gradient, and then a loss of glutathione. That loss of glutathione, which is the major endogenous antioxidant, corresponds, we think, to a gain in reactive oxygen species. And this is in fact what we found in the same TBI model. And I won't go through all of these because we're a little short on time, but ultimately what this shows is that in the injured tissue, and not just in the injured tissue, but in tissue near the injured tissue, there is over time a progressive loss of glutathione, as we would expect with this loss of glutamate transport. So these are the downstream consequences that are interesting of traumatic brain injury. Interestingly, you could rescue this phenotype of injury by giving an acetylcysteine, which would overcome that transporter and provide substrate to manufacture glutathione. Now, we would like ideally to restore this glutamate transporter. And so one of the things we're looking at is what molecules may upregulate this glutamate transporter. And for a crazy reason, beta-lactam antibiotics do it. It has nothing to do with their antibacterial properties, but they just happen to be a good fit. And it turns out that this is about 20-year-old news that in a large drug screen, beta-lactam antibiotics stand out because they cause an upregulation of this glutamate transporter. So sure enough, if we give ceftriaxone to an injured animal, we restore, that's what's on the y-axis in this bar graph, the amount of this glutamate transporter. If we do this early after injury, we reduce the amount of reactive astrocytosis, that's what's in the GFAP graph here, and we reduce the amount of seizures. So if we think that loss of this glutamate transporter is a component of epileptogenesis, from which the downstream consequences of glutamate-mediated excitotoxic injury to the PARP cells, glutathione-mediated oxidative injury to the PARP cells, eventual loss of the PARP cells, and eventual loss of cortical inhibition, then we potentially have something anti-epileptogenic in a common beta-lactam antibiotics. We give ceftriaxone to babies with meningitis. So that's my long way of saying that we have something interesting that's potentially anti-epileptogenic. So why am I talking about glutamate transporters in the astrocytes and provalbumin? And I skipped the slides on the paraneuronal net and other components that we're also interested in. And why is this of use to a TMS lab? And the reason is that we, again, have potentially a biomarker in TMS, specifically in paired pulse TMS. And this biomarker lets us look at not just epilepsy, but at metrics that reflect this acute glutamate release, oxidative stress, and progressive loss of parvalbumin cells in epileptogenesis. And not only do they let us detect it, but if we do this in an animal model, and we looked at this paired pulse TMS protocol, where we look at the ratio of two consecutive motor responses as a readout for how intact is cortical inhibition, we can potentially have a biomarker that tells us, one, that epileptogenesis has started, and two, whether or not something that's potentially anti-epileptogenic, which may not be an anti-seizure drug at all, it may be something unrelated, has changed or at least arrested this pathophysiology. So our postdoc, Mustafa Hamid, in fact, found exactly this. If we look now at injured rats treated with ceftriaxone in the dotted line or with saline in the solid line, in the same protocol where weeks after injury, we ask, how's the cortical inhibition? How's the cortical inhibition? The higher the value on the y-axis here, the less paired pulse TMS inhibition of the motor potential we have. You can see that this cortical GABAergic inhibition is preserved with ceftriaxone treatment and lost, as you would expect, with saline treatment. And if we zoom in on the parvalbumin cells, again, we can see that in the treated group, the perilesional parvalbumin is also preserved. So now we have TMS as a biomarker for us of an injury to the inhibitory circuitry of the cortex and of a salvage of the inhibitory circuitry by a therapeutic. So that's the quick drive-by of the interesting part of paired pulse TMS. And since we're a little short on time, let me skip directly to the other kind of TMS, the third kind, repetitive TMS. This is, of course, the capacity to stimulate the brain over and over again at a high frequency to interrupt something that an individual is doing. We, in fact, use this to map the language cortex. We can ask somebody to participate in a naming task, and when an image flashes, we ask them to name the object. And if we're stimulating at 5 or 10 hertz over pars triangularis and Broca's area, they stop talking. Or alternatively, we can ask if they have a drug-resistant seizure focus and stimulate at a low frequency, hopefully to induce something that resembles long-term depression of excitatory synaptic strain to see if we can suppress their seizures. So this is where TMS is being used in a few laboratories in epilepsy. And so here's one example. This is actually a 40-something-year-old patient, one of the early ones from close to 20 years ago, who had a vascular malformation resected at Children's Hospital at about age 17, and then for a couple of decades had right-hand EPC, like literally decades, and learned to play basketball with his left hand, was functionally walking around without a functional right hand, and had you could see here, this is an average montage for the epileptologist, and this is a P7 positive component of the dipole that he otherwise had at C3, but we had to remove C3 to put the coil on. So these positive spikes are showing us his essentially constant EPC spikes. And after a train of 1800, a half hour of 1 hertz stimulation, which would in a slice presumably weaken excitatory synaptic strength, we could see that these spikes resolve. And we've done this actually very early on as therapeutic TMS in cases of EPC. We published a small series many years ago where about a third of patients would have their EPC arrest. EPC, epilepsy partialis continua, focal status epilepticus, doesn't stop. And it can go on for days or months or years sometimes and just remain that way. And in about a third of cases, and these stats have held up ever since. In about a third of cases, you see something very dramatic. You deliver trains of TMS and the seizures stop. And when they stop, it's quite conspicuous. In about a third of cases, they pause for about 20 minutes after every stimulation train, then they just come right back. And in about a third of cases, nothing changes. That's roughly the efficacy that we see for ongoing seizures. Of course, in epilepsy, there's 2 places to deliver treatment, ictal and interictal. So the ictal role for TMS in aborting focal status epilepticus seems to be there. It doesn't work in everybody, but when it works, it works. And interictal TMS is still in development. And the idea for interictal repetitive TMS is to stimulate the seizure onset zone at a low frequency to depress cortical excitability in that region and hopefully reduce the seizure frequency. This has been done by a few groups with variable success. The one that was successful was Wei Sun, who we actually had in our laboratory for a little while from Beijing, who delivered low frequency, in this case, half hertz TMS to the seizure focus in a cohort of patients with focal epilepsy on the convexity, so easy to reach by a TMS coil. And they had weeks of seizure suppression, quite meaningful. On this graph, placebo group had no change in seizure suppression. I should say that all of these patients eventually bounced back to their original epilepsy. We've done something similar. This is a study that we ran with a special kind of TMS coil called an H coil that wraps around the skull and can induce current about 4 or 5 centimeters beneath the skin, so potentially could reach mesial temporal structures. So we ran a trial for temporal lobe epilepsy and also saw that in the sham condition, the white bar here, not much effect, and in the verum condition, for those on Zoom, a gray bar here, but with an appreciable suppression of seizure frequency. And this doesn't work if I just talk about it, but let me explain it for those who don't see the graphic, which is that we are often self-congratulatory in epilepsy when we can reduce the seizure frequency and put a p-value on it and put an asterisk over the bar graph. And we can reduce seizure frequency by 50% from somebody who has 8 seizures per day to 4 seizures per day, and that's wonderful. Except that patient still can't drive. And realistically, the good-looking bar graphs, which is what I showed on the previous slide, don't quite tell the full story. The slide that I'm showing now on Zoom shows a patient's daily seizure count. And the red and blue correspond to mild and severe seizures. But you could see on the graph that the patient has a few seizures per day, and they pause for the duration of TMS, and then they gradually come back, not as good as their baseline. So if you were to average the seizure frequency before and after treatment, you'd make a good bar graph, but this patient is still not going to drive. And so the practical question is, how do we improve from this scenario? where we try TMS and we have nonetheless some relapse of disease. And one way to improve, and the graphic I'm showing now is just a picture of a rat getting TMS again, is to really reduce this to an animal protocol. And the value of animal models of epilepsy is you can have wholesale numbers. Realistically, with any stimulation protocol, TMS, DBS, VNS, you name it, the parameter space is very broad. The range in frequencies and train durations, etc., is impractical to test in humans. But in rats who have ongoing seizures, you could test in hundreds of seizures, all by the same mechanism, a whole range of frequencies, for example, and see whether or not a quarter hertz low frequency stimulation works as well as half hertz, works as well as 3/4 hertz, etc., and bounds through gradually small changes in the parameter space in a practical way to identify what form of stimulation works best for what kind of epilepsy. And then, since these devices are already available and they're non-invasive and they're in humans, you can again forward this pretty rapidly to a clinical trial. And if you found in a rat model that 1.25 hertz was somehow superior in suppressing seizures to 1.0 hertz, no IRB would object to making that kind of change in your protocol. So that's the value of doing this in an animal model. With this, I'll wrap up because we're a little bit short on slides. I'll show you the slide that I'm showing now, though, which is really cool. And I don't know if you could see it on Zoom. And this is, in fact, Jacques-Arsène d'Arsenval, who was a French physiologist who was one of the earliest people to show that induced, as opposed to conducted, electrical current can affect the brain. And so for those who can see the picture, what you could see is an individual putting himself into an electromagnetic coil, and then this guy would volunteer that he saw phosphines flashing lights and felt dizzy and felt vertigo whenever he had induced current around him. And the cool part of this photo, at least that's what I heard about it, is who these people are. And so the guy putting himself into the coil is the lab postdoc. The guy running the equipment is the lab technician, and the PI of the lab is off to the right, taking credit for everything. So for those who can see on Zoom, lest you think I did any of the work that I showed us from our laboratory, I promise I've done none of it. This is entirely the work of these young investigators whom I'm showing now, who are really doing the heavy lifting in our laboratory, as I'm sure in every laboratory. So everything you like is their credit, everything else is mine. And I'll just wrap up here. So thanks.
I have a simple question.
Yeah.
How do you co-register those magnetic invocation, whatever the word is, with the MRI?
Oh, yeah. The co-registration. Oh, sure. It's actually a pretty
important in terms of what we're saying.
You're right. It's a very straightforward procedure. So the question for the Zoom is how do we do the registration? So participants, by the way, these moms gave permission for their photographs, wear infrared reflecting, small infrared reflectors that can be picked up by a stereo camera. The stereo camera has what it sounds like has two lenses, so it can actually detect a position of objects in three-dimensional space. And the registration is done to durable head and scalp landmarks. So the crus helix, which is a part of the ear cartilage that's pretty durable, you can actually see an MRI pretty well. And the nasium, you can see an MRI pretty well. And so if you register those, you have three rigid marks that are registered to a fixed reflector on a patient's head. And then if you then identify by a stylus the surface of the scalp, you can have a very good idea of now where the brain is in that individual in three-dimensional space.
Sounds complicated.
It's
not like doing PET and MRI or PET and CT.
No, I promise it's easy. Yeah, this is actually something that's very, yeah. And the readout actually is very precise for us. In other words, again, the motor cortex tells us how precise we are. Because in a healthy brain, if we have a very conspicuous hand omega and a precentral gyrus and we stimulate there, we don't get any other muscles. Yeah.
Dr. Papamasakis has a question on the chat. He wants to know if there is any recent advancements on the use of TMS for post-stroke patients for motor recovery.
Yes. Recent is already 5-10 years, but yeah. So for post-stroke recovery, there's actually an interesting pathophysiology of motor cortex stroke and an interesting TMS protocol. So the cool pathophysiology is that when there is a motor lesion, there is necessarily a loss of transcallosal signal from that motor lesion to the other hemisphere. That transcallosal signal is largely inhibitory, which is why it's hard to pat your belly and tap your head at the same time. But if you have a stroke in one motor hemisphere, it'll translate to a disinhibition of the contralesional hemisphere. And that can actually be picked up by PET, by fMRI. If there's a lesion to one side of the motor system, the other side becomes hyperactive. Since that other side is hyperactive, its output to the injured hemisphere is inhibitory. And if there is any motor system left in the injured hemisphere, its recovery is impeded by the inhibition from the overactive contralesional hemisphere. So the TMS protocol that seems to work is low frequency inhibitory suppressive stimulation over the contralesional, the good hemisphere. It's a little counterintuitive, but suppressing activity in the good hemisphere seems to correspond to an accelerated motor recovery. Having said that, that acceleration in motor recovery is modest. And there's actually one company trying to push this now toward FDA approval. It's there, it's some value in stroke rehab, but it works best if you couple it with robot to movement, stroke rehab, et cetera, et cetera. Yeah, in isolation, it's a weak signal, but if you combine it with the usual therapies, an aggressive motor therapy that patients get, it seems to work. Yeah. Yeah.
In the data regarding the motor evoked potentials in the right left-handed patients, which is a work in progress, have you looked at it stratified by the hemisphere where the focus is present?
Yes. It doesn't seem to make a difference. Yeah.
Very pathogenic.
Most of our patients walk around with a lower threshold to activation in the left hemisphere versus the right. If there's a seizure focus in the right hemisphere, that the right is even higher. And if there's one in the left is even lower. So the relationship of who's higher and who's lower remains the same, no matter which hemisphere the lesion is in. And it's only this aberrant ratio where there's a lower threshold for activation in the right hemisphere that seems to predict a poor surgical outcome. I shouldn't say poor, but suboptimal surgical outcome. And probably what it says is that the disease is so diffuse that at least the motor system somehow is involved. And since none of these patients have a lesion in the motor system, that means that the disease has spilled out of its lesion. Yeah.
You said something briefly. I think you have an underlying model of the state with a single pulse stimulation. You say, even though you're stimulating an intact region of motor cortex, it reflects some pathology somewhere else in the hemisphere. So that's assuming there's some tonic inputs that reflect. Can you go into that a little bit?
I wish I could in any detail, except that it's there. There is almost necessarily, I think, continued input into the motor cortex from the basal ganglia, from the cerebellum, and from premotor areas, even when there is not a volitional movement, that there's some tone of activity.
That's inhibitory?
It seems to be in aggregate. I mean, I'm sure they're but the net seems to be an inhibitory tone. And we could see that in some diseases. In other words, the features of basal ganglia injury, for example, is a tremor. It's some excess in motor activity. It's a caricature way to look at it. But there seems to be a net inhibitory tone to the motor cortex. Depending on what's the measure out of the motor cortex, it may not matter if it's net inhibitory or excitatory. In other words, if what you're asking is, did drug X reduce cortical excitability? You could ask, did drug X increase paired pulse inhibition of the motor neuron potential, or did it raise the threshold to activation of the motor cortex? Either of those would potentially be useful, I think.
I think you said the single pulse with the ratio of the two, and I can't remember exactly where it came up.
What the ratio is more of so the ratio in the threshold to activation between the two hemispheres seems to be just something innate, where in a healthy brain you should have unequal excitabilities of the dominant and non-dominant motor system. And if that's altered, that speaks to a disease that has an anatomy that at least includes some part of the motor system. So if you have a well-defined temporal lobe seizure focus, it may or may not respond to surgery if you remove it. If you have a well-defined temporal lobe seizure focus and you have something abnormal in the motor system in that patient, you can say this disease involves more than just what you see abnormal in the MRI. It's something a little more network dependent, a little more widespread because the motor system is involved. That could be where I said it. Alternatively, it could be in the paired pulse stuff where, yeah.
For the pathophysiology of post-traumatic epilepsy, is it like loss of inhibition neurons and also glutamate transporters? Do you think that also applies to like post-TBI syndrome, like
yes, we think it does. So we've actually done a little bit of work in mild concussion and repetitive mild concussion in mice, and we do see also this progressive loss of glutathione and cortical inhibition and provalbumin. It's not on the scale that we have it in post-traumatic epilepsy, but what we think is that post-traumatic epilepsy is just a more conspicuous version of a pathophysiology that's just there after brain injury X. And the mild brain injuries behave in a qualitative way, at least at the provalbumin and glutathione level, in the same way that the severe injury does. It just may be subthreshold to produce seizures. Having said that, even if you look at the human literature for seizure likelihood after concussion, it is slightly increased. It's increased a tiny bit, but there's a lot of concussions, so actually adds up probably to an appreciable number of patients with epilepsy.
Do you think they can like benefit from CNS therapy?
Well, in the case of post-traumatic syndromes, but no one was focusing on the epilepsy, TMS we're not really using it as a therapy. We're using it as a diagnostic to tell us whether and how much cortical inhibition has an individual lost, and whether and to what extent some intervention has prevented that loss.
Does that mean that it gives a try someone to become involved in traumatic pain?
We do not yet. But who knows? Maybe we will soon. Now, ceftriaxone might not be the most benign thing to give. We actually have a grant that's funded now that we're looking at non-bactericidal beta-lactams, sulbactam and clavulanate, which in principle are less bothersome to gut flora, etc. Shouldn't lead to antibiotic resistance and shouldn't cause C. difficile superinfection, etc. And we'll see if those work. They seem to.
Otherwise, I'd see it for months. And
So is that the studies your animal studies, right? Like,
These are animal studies so far. Yeah.
the unrelated question, do you guys use ferroptosis for the translation salvage?
No, we do not. I'm out of my depth. I wouldn't know how. But I can imagine that looking at a lipid membrane readout of oxidation would be useful. Yeah.
A quick question.
Okay. Well, thanks guys for putting up with the technical hurdles. Oh,
One last
Hey,
comment.
Dr. Geary?
Yes.
Oh, I'm
wanted
sorry,
to
I'm
say,
unable to hear you.
Is it better now? Are you able to hear?
Dr. Geary, I hear you on Johanna's phone. Yes.
Okay. Basically, I want to say amazing presentation. Thank you. And thank you for mentioning the giants of downstate, Dr. Roger Krakow, Amassian, and of course, Damadian had a lot to do. So
Okay.
I wanted to just tell the younger participants in the audience that we have a great heritage that we can be proud of. And we are very proud of you, Dr. Rotenberg.
Oh gosh, thanks, Dr. Geary. I appreciate it.
I could add that Alex did important work in this PhD project. I think the first in the world to report from single neurons in behaving mice, working with Eric Kandel and Bob Mueller. And got lots of New York Times. Well, yeah.
All right. Well, thanks very much, everybody.
Thank you.